So ERAS is a newer thing at UT Southwestern, however, has been around for a while. So it started in the 1990s in Denmark. A professor came up with this idea to transition from a fast track to enhanced recovery after surgery. It involved more evidence-based practice and research with the ultimate goal of reducing the surgical stress response, supporting physiological function, accelerating patient recovery, and improving outcomes. So the ERAS Society was formed over in the UK and Europe in 2010. At the same time, Duke University in the United States also formed, they had an ERAS program that they began. The first national congress for ERAS was in 2012, and then our first one here in the United States was in 2014. And then they formed the American Society of ERAS, of Enhanced Recovery. So there's several societies, the ERAS Society internationally, and then the American Society for Enhanced Recovery. All of these websites are great resources because ERAS isn't one of those things where they try to hide their guidelines and protocols because this is ours and we want to keep it ours. They publish all of these guidelines and protocols nationally so anyone can use them as a resource for their institution, so they don't have to reproduce it if they want to kind of use those as a guideline to make their own ERAS protocol. So you'll hear multiple terms. Enhanced recovery is one of them, enhanced recovery pathway ERP, which you'll see a lot here, and then ERAS, which is enhanced recovery after surgery. All of them are enhanced recovery and mean the same thing, just different ways to say it. So they've estimated that based on surgery and anesthesia outcomes from surgery, there's always a risk of 25 to 50% of complications, depending on the complexity of the case, but usually an average of 25% of patients have a complication from anesthesia or surgery. And so they decided to embark on this ERAS society and committees to improve patient outcomes and reduce variability so that there was less complications, better patient outcomes for the patients, and also there was some consistency among different institutions and how they were actually delivering care. There are other reasons they were deciding to develop ERAS was, there's been discussion for a long time that Medicare eventually is going to go to bundle payments. They're now not reimbursing for these complications that are preventable errors or never events as well. So hopefully ERAS will minimize some of those as well. So the American Society of Enhanced Recovery talks about some 4 principles. These principles and the guidelines were actually written by T.J. Gamp. If you guys had the ability to go to the ERAS Symposium, he was our keynote speaker. He's instrumental. He's the president of the American Society of Enhanced Recovery, and he actually had a dinner not too long ago, and he came back and spoke to us. Edwards has a large investment in our institution in that we're new and up and coming on ERAS, and we're going to be participating in some studies here upcoming, so they are open to any education to any perioperative area as well. We can get them in here to speak to you guys a little bit more about stroke bond variation and all of that as well in the future. So the 4 principles are that the patient is a partner in their own care. So they're actually part of the team that's participating. In the past, the patient was separate from the healthcare team. Patient optimization, that's for pre-surgery. We'll talk a little bit about pre-operative, making sure that they're in the best health state, that they've had all the workup necessary to make sure when they come for surgery, we minimize any other potential complications. Evidence-based management, so that's all that evidence-based research. Rather than just looking it up individually, now we've looked it up and we've put it on paper and so everyone can read all the literature that we found. And then best possible care and rehab for patients. So all of this involves an interdisciplinary approach, and we'll elaborate more how the perioperative area should be focusing on this all the way from pre-op to intra-op, post-op, and even when they go home. So that little chart on the top, you'll hear it. It's called the triple aim of healthcare nowadays. Several sources will refer to it. That talks about population health, cost of care, minimizing that, especially with the bundle payments and all of these events that are not reimbursable by Medicare and Medicaid that are preventable. And then the patient experience, which is very important nowadays right now because they talked about reimbursement being based on the patient's feedback and experience. So customer care is also important in healthcare. So these next 4 slides are exactly the same thing, but several different ways to look at it. This one is one of my favorites because it's the simplest. It talks about the elements of enhanced recovery, pre-op, intra-op, and post-op. So to focus more on post-op, since you guys are PACU nurses for this lecture, post-op, it talks about judicious IV fluids. So we'll talk about stroke volume variation and fluid management intraoperatively and how that fluid management should continue in the post-op period. Multimodal analgesia, and I know you guys have heard that a million times, that's a huge part of ERAS and making sure that these patients minimize the amount of opioids and the complications related to opioids. Get them eating, get them up and walking, teaching from in the pre-op clinic all the way through PACU, reminding them of what ERAS is and what their responsibility is. Some institutions actually have websites, apps on their phone, and it walks them through the entire ERAS process, so they know exactly what the next step is for them. And I hope that UT Southwestern is working on a website right now, from what I understand, and we'll come to that in the future, so the patients can be actively involved and they can say, well, here it says I'm supposed to do this, and I haven't gotten this, so they can kind of remind everybody as well. And then clear defined discharge criteria. So this next one is everyone's favorite. It also is a little simpler. This one is one of the most frequently cited diagrams. The one it adds on here that it doesn't have on the other one post-operatively is early removal of drains and tubes. So if we don't have to have an OG tube or NG tube, we take it out as soon as possible. The old school was, well, just in case if they had bowel surgery, let's keep it in, right? Just in case, because we're worried about an ileus and peristalsis. But now they're saying, you know, get them up, chewing gum, drinking water, and get that tube out. It'll help. It'll help decrease their length of stay and then improve patient outcomes and also, you know, patient's experience as well. Multimodal, once again, early mobilization, early intake of fluids and solids, and post-discharge follow-up. So the next diagram here is the one that I'll use for the basis of most of this presentation. This one's actually from the AANA, the American Association for Nurse Anesthetists. And so this one kind of just divides it a little bit more categorically. So we can go to the next one and talk about pre-op. The pre-op section is actually one of the most important. So pre-op education. So all the articles talk about this education product to give knowledge. So ERAS is a product. So we are not giving it to all patients. They have to have certain, you know, if they have certain contraindications, they don't qualify for ERAS. But if they do have the ability to have an ERAS protocol, it is the option for the patient to participate, as well as the suggestion from the surgeon and the surgical team in the office. So they need to explain first what is ERAS, because it is something where it's not necessarily we're selling, but we're saying, hey, this isn't an option. ERAS is an option for you. And then explain what the process of ERAS is to promote engagement with the patient. So you can't just say, oh, we have this enhanced recovery, it's going to get you home earlier, it's going to help, you know, save costs for the hospital. This is what it can do for you. And so the patient can be involved in their care. And a lot of them, surprisingly, like being active in their own healthcare. And then there's this step of you have to make sure they have situated understanding of what it is, confidence building, and so making sure that they have confidence in this process along the way, partnership with all of the healthcare professionals involved from pre-op to intra-op to post-op, and then proactive involvement of the patient. Again, you know, the future of ERAS would be websites, apps, and things so they can interact. And then eventually all that leads to enhanced recovery. So when you first initiate enhanced recovery pathways, they're not always evident or successful in the beginning because it is a process of implementation. So pre-op clinic, these are the things they teach in pre-op. Our physicians are staffed over in PST as well as our CRNAs. It's a certain group. They've all, they have handouts that they give to the patient. They have pathways they show, and they do extensive pre-op education. So the big thing is smoking and alcohol cessation. We want to make sure it's at least 4 weeks prior to surgery. Stopping them in 2 weeks prior to surgery can actually lead to increased secretions and potential airway complications, irritable airway. So we like to make sure we give them a good time frame. They provide resources to help them stop smoking as well. Further risk stratification. So this is where we define if it's low, moderate, or high risk for surgery, and if they're moderate or high risk, do they need to go for an echo or cardiac clearance? The American Heart Association has clear defined pathways for that. Laboratory testing per protocol. So Megan Maxwell, she's instrumental over in the PST clinic of giving them a list of labs that they need, and especially for these ERAS, it's all on the protocols. Carb loading, this is what is so new, is the patients can actually drink before surgery. So especially for a lot of the surgeries, like the bowel surgeries, they encourage them to drink what's called Clear Fast or Gatorade that has at least 45 grams of carbs 2 hours before surgery, making sure it's a clear. And what that does is it prevents the hypovolemia that you see intraoperatively, and it helps with their nutrition preoperatively. So there's not a larger gap in NPO status. And you do see a significant difference intraoperatively if your patients actually had something to drink in the morning. Their blood pressure is more stable. It's not as hypotensive at times when you induce anesthesia because, their volume status is much better. There's nutrition screening, which we'll go into more detail in a second. Setting appropriate expectations. Patients will have pain after surgery. It's like the hardest thing to tell them. They will have pain. So the expectation of having 0 for your pain, potentially has more harm than good to the patient, and they need to understand that. Having a pain of 3 to 4 is acceptable, and understand the coping mechanisms around that. So we try to tell them in pre-op, before they've even been to the hospital, before they're anxious, before they've had Versed, so they understand this well in advance. Ostomy consultation has been a big thing. The ostomy nurse will go over there and will mark the site for their ostomy, so they have some control over the location of it, making sure that it's appropriate for their pant level, so it's not going to create an issue, and then that marking stays on there so that the surgeon knows for the day of surgery. Medication management, prehabilitation. This is something that we're working on, but we're not at yet. Some facilities have a prehabilitation clinic where patients can come in and exercise and do some kind of therapy beforehand, get some nutrition advice, dietary intervention, coping strategies, and so it's a full clinic that patients can come in to kind of, again, optimization prior to surgery. So this is the American Society of Enhanced Recovery consensus for nutrition screening. There's a lot of information on there to highlight the main things, especially for you guys post-operatively. Preoperatively, they set a protein goal of 1.2 grams per kilogram per day, and then afterwards, protein is the most important total calorie goal for them post-op when they're starting to regain their diet. The patients, they talked about this immunonutrition, which is arginine, omega-3 fatty acids, and antioxidants prior to surgery. So arginine is rapidly depleted after surgical stress to anesthesia, and it's important for T lymphocyte activation, T helper cell promotion, and phagocytosis, which is all part of the recovery process. And then omega-3 fatty acids, as we know, play a role in anti-inflammatory. So if the patient needs nutrition prior to surgery, they're starting to do this immunonutrition. Then again, the preoperative carb drink of at least 45 grams. Postoperatively, drinking fluids, chewing gum, getting them up. Immunonutrition can also be considered postoperatively, and then recommend standardized protocols for post-op nutrition support. So that's something I think that we have a lot preoperatively, but we could definitely stand to work on postoperatively to make sure that they maintain the appropriate nutrition. On the next slide, you'll see that there is some of the guidelines. So if their BMI is low, or if they've had unplanned weight loss, or have they been eating less, if there's any of those reasons that they say yes, they definitely, and especially if their albumin is low, they need a pre-op nutrition screening, and we'll formally put in a consult for a dietitian to talk to them preoperatively. So this is just a little diagram. Carol Boyle is actually our CRNA in charge of the PST clinic. She spoke at the ERAS symposium. A few of these slides I took from her lecture because they were so great. This one's really good to show that 2 out of 3 patients coming in for surgery, especially GI surgery, are malnourished. They have a 3 times greater risk of having complications in surgery and 5 times more likely to die than a nourished patient. And only 1 in 5 hospitals actually has a formal nutrition screening process. 3 out of 4 surgeons believe that nutrition delivery will reduce complications. For every $1 spent on nutrition therapy, it saves $52 for the hospital, but only 1 out of 5 patients actually receive any nutrition intervention. So there's definitely room for growth in this area for us. Okay, so this is intraoperatively. So this is what a protocol looks to us like in the OR. We receive the patient from pre-op, and we kind of zero in on this intraoperative. This is a cystectomy. It's one of the easier ones to kind of put up here. They're all categorized with the same categories based on what that chart says on the top. So there's always something for multimodal, opioid sparing. So most of them say, ketamine or lidocaine infusions. We give IV Tylenol, local anesthetic at the site, or peripheral blocks postoperatively. And then most of them all say short-acting agents for narcotics. So low-dose fentanyl, 25 to 50 mics, minimized, long-acting like Dilaudid. Normobulimia, in the next couple slides we'll talk about stroke volume variation. There's, as you see in the cystectomy, one of these longer procedures where fluid management is important, there is an actual algorithm for how we give fluids intraoperatively. And again, the Edwards is about to do a study. They have a flow track module that doesn't it provides more than a stroke volume variation. It provides an algorithm that they're trialing here for a study. And that algorithm, you can plug in if the patient gets a bolus or blood, and it assesses, it'll tell you if the patient actually needs fluids or not, and you'll give it, and it'll tell you if the intervention worked or not. And so they're creating this, it's a huge study they're doing all over the United States, and UT Southwestern is part of that study. It's just in the beginning phases. Nausea and vomiting prophylaxis. A lot of the protocols have skilled patches and amend and pre-op. We'll talk a little bit about this in a second. And then intraoperatively, we usually get Decadron and Zofran. Normothermia is important. Talks about that. Basics of normothermia, especially on your flat cases or your breasts. Patients tend to get very full. Normoglycemia. Now, not all the protocols talk about that, but intraoperatively, we do check blood sugars for longer procedures, especially if they're diabetic, and treat them. Avoid tubes and drains. So you'll see most of the protocols give you a recommended antibiotic based on what the literature says is the best antibiotic to give. Parkland really only has one ERAS protocol, colorectal, and they've had it in place a lot longer. I think it's shortly before we had our first bariatric ERAS protocol. And the physician involved in that, they have done a lot of measurements of post-op infections from colorectal surgeries. And with the ERAS protocol, they significantly reduced the amount of post-op infections, just based on the ERAS protocol and then the antibiotics. In fact, when Dr. Olson came to the ERAS symposium, he was doing research for his presentation and decided that new research says he should shift what he was giving for antibiotics to, I think it's Ansep and Flagyl. So they've actually revised the protocol based on current research that needed to be updated. SCDs, subQ heparin, it'll tell you kind of the recommendation for the IV access you should use and the fluid management. And then again, we'll talk about stroke volume variation. Avoid OG tubes if needed. Communicate with the surgeon, especially if the patient gets gabapentin and Lyrica and all sorts of drugs preoperatively. We don't want to put in an OG tube and suck it out because it does no good. So, okay. So stroke volume variation, what is that? You'll hear that term a lot more. It's not the same thing as a pulse pressure variation because it's on the art line, so it's more invasive and it's a better indicator. But fluid resuscitation is one of the first therapeutic interventions to optimize oxygen delivery, and the best thing we can do for a patient intraoperatively is optimize oxygen delivery. So what is stroke volume variation? It's due to the changes of intrathoracic pressure secondary to negative or positive pressure ventilation. So I'm going to focus just on positive pressure ventilation, but when the patient is spontaneously breathing, that's negative pressure ventilation. And what happens to your intrathoracic pressure with your inspiration and expiration for your pulse pressure waveform is the opposite with spontaneous ventilation than what we'll talk about here. So when the patient's on the ventilator with the recommended 8 milliliters per kilogram tidal volume with a fixed respiratory rate, when they breathe in, the pulse pressure variation increases, and then when they breathe out, the pulse pressure variation decreases. So as you can see in the diagram, so with inspiration and controlled ventilation, the pulse pressure variation is up, and with expiration, it's down. So this is an indicator of preload responsiveness. The greater percent of difference between that inspiration and expiration changes in pulse pressure variation means the patient needs fluid, more than likely. They're hypovolemic. So in the OR, we actually get a number on the machine that tells us their stroke volume variation. And so we monitor it. A lot of our machines actually have like a green, a yellow, and a red. So you can kind of like, green is good, and yellow, you probably need some fluids, red is bad. There's a lot of factors that can affect it, so we have to assess to make sure that it's actually accurate. But you will notice once you give a fluid bolus, if they were volume down, the SVB will go back down. So it's affected by arrhythmias, high peak levels, vascular tone, spontaneous ventilation, tidal volumes, respiratory rate, position. The patient's on their head of Trendelenburg in a robot case, it's not going to be as accurate. So, and then on the next slide, it gives you an example. So this is an example of a case. This is what the screens kind of look like from some of the Edwards. This is an older one. Some of our newer models are a little bit different screens. But as you see, the patient's stroke volume variation was 19. Intraoperatively decided to give a unit of blood, and they gave some NS as well. And so when the stroke volume variation was high, they needed fluid, their cardiac output was lower, so they were impacting oxygen delivery. They gave a fluid bolus, their stroke volume variation improved, so they had less change in the pulse pressure variation between inspiratory and expiratory pressures, and therefore the cardiac output went back up, just in response to the fluids. And as you can see, the patient trends back up to a stroke volume variation of 16. Usually we try to keep it 10 to 15% or less, 10 to 15 depending on the patient. we start giving fluids or doing interventions, but it significantly for this patient impacted their cardiac output. And I actually saw this in the OR when a patient lost 3.5 liters 2 days ago. Their stroke volume ratio was 32, and their cardiac output dropped by half. So, okay, so postoperative phase. So let's just look at the nausea, vomiting, and multimodal pain real quick, and then I got 10 minutes left. So in PACU, again, chewing gum, sips of clear liquids as soon as possible, pain control, communicating with the team to see if they've already had Tylenol, what did they get preoperatively, so you know what they had, and then especially knowing when their last dose of fentanyl is, if we titrated someone at the end. It usually be slower doses. Some patients need some water when they wake up, and we might give small doses. So for antiemetics, this is the chemoreceptor trigger zone that's in your brain in the emetic center. So everything we give to prevent nausea and vomiting is called an antiemetic. We have multiple drugs that work on the center just based on all the receptors that are on there. As you see, we have, almost 10 receptors that are located on that. So patients that are high risk for nausea and vomiting, we try to give 2, 3, 4 more drugs. They say if they've had a known post-op nausea and vomiting that you definitely want to give at least 3 or more to help prevent it. And then if they, even with the 3 or more, they still have post-op nausea and vomiting, sometimes we'll switch to TBET because propofol helps prevent nausea and vomiting. So Zofran works on the serotonin receptor, the 5-HT3, your Reglan and droperidol, which is a great drug, unfortunately, is not available anymore. It is a dopamine antagonist, so you'll see it works on the dopamine receptor D2. Amend is actually works on the NK1 receptor antagonist on the top right, that substance P. Yeah, so it's a substance P inhibitor, and that's where Amend or aprepitant works. Again, one of those drugs that can, even on one dose, limit the effectiveness of the oral contraceptives, so giving them a letter, making sure they know they need additional coverage. Benadryl and Phenergan. Benadryl works on the histamine receptor. Phenergan also works on the histamine receptor as an antagonist. Your Decadron doesn't really necessarily work directly on the pathway. It's an adjuvant to that antiemetic center. So that one's still speculation of how it works, but it works. And scopolamine is a muscarinic receptor, but also an H1 antagonist. So all of those work on the antiemetic center. So you see how you can give a dose of Zofran, and then you can give another dose of Zofran, but then maybe that's not working for the patient. There's a lot of other drugs we can give to affect those receptors. You'll hear the term multimodal a lot with ERAS and in general because the opioid crisis is real and it's now. Not only is it one of the top causes of death and mortality rising in the numbers, it's actually it's up from, it's a leading cause of accidental death in Americans under 50, and we're up from 20,000 of 50,000 of patients dying from opioids. And then if you think about it, in 2012, 256 million prescriptions were written for patients. So we've come a long way. I think we're doing good, but we still have work to do. The other big concern is all of the drug shortages. So we don't really have any narcotics as well. So even if there were an opioid problem, we have an availability problem. So you can see the old pain pathway was patient assessed, they had pain, you treated, right? Whether it was an opioid or non-opioid, and then they were discharged, and that was it. But now, preoperatively, they do education about pain. You will have pain postoperatively. These are things we can do for you. So they minimize fasting to reduce anxiety, do any kind of blocks with regional anesthesia. In the OR, we give nerve blocks and analgesia as well. Postoperatively, we try to also stick to the multimodal with Tylenol, gabapentin, and other drugs. And then again, still when they go home, they might get a prescription of drugs, but it might not be as much, and they encourage them to not take them unless they really need them. So here is a diagram of pain transmission. So the term nociception is the perception or sensation of pain. And so if you start on the right, you have transduction, which is first. So transduction for us in the OR is the surgical stimulation, the cutting of the skin, the damage of the tissue, the injury. And so you have that transduction to transmission. So it sends it through the peripheral nerves, sends it up your spinal cord, where it's called modulation. There's peripheral modulation because there's modulation at the side of the spinal cord, and then it sends a signal all the way up to the brain, and there's central modulation. And that actually, when it gets to the brain, is there's perception, which there's several types of perception. There's the perception of what this pain does to me, which is like the limbic system, and the actual perception of the pain itself. So sharp pain versus dull pain. So if you look, transduction, there's several drugs we give that work on it. So our local anesthetics we give locally, our NSAIDs that we give like Toradol. We don't really use COX-2B inhibitors anymore, specifically the Celebrex, because of the black box warning. So COX-2 inhibitors stimulate the release of prostaglandins, which create inflammation. One of those prostaglandins is prostacyclin, which prevents your platelets from sticking together. But if you inhibit that pathway with a COX-2 inhibitor, then those platelets start sticking together, so it leads to an increased risk of stroke or MI. So you will see some people still use them. It's not recommended, especially in high-risk patients. We also give preoperatively gabapentin or Lyrica. Some patients are on clonidine for pain, or they add clonidine to the local anesthetic. And those all affect transduction, but gabapentin and clonidine also affect modulation. So it's multi-use. Transmission, again, local anesthetics can affect the transmission. Modulation, peripheral modulation, we don't really give COX-2B inhibitors anymore, but you still give gabapentin and clonidine and Lyrica. And then ketamine works in the brain on the NMDA receptors we'll talk about, and that works on the perception of pain. So what is the term preemptive analgesia? So the first phase of pain plays a critical role in central sensitization. So what is central sensitization? So surgical stimulation is called noxious stimuli in the OR, and so it sensitizes the pain pathways, the brain, all of the nerves to additional surgical stimulation. So in the future, that surgical stimulation and subsequent stimuli might be perceived as worse in the perception. So that's called central sensitization. So an amplified response into the same stimulation or same pain is called hyperalgesia. And then pain that the patient actually feels for things that shouldn't cause pain is called allodynia. So these are a couple terms you'll hear. The most important part of it is that we know when the onset of pain is in the OR, and if we give something before the stimulation, we're preventing it, then you don't stimulate all of this pathway that's going on, so therefore your brain doesn't get sensitized to future pain signals. So you'll hear preemptive analgesia a lot. As you see, local anesthetics work at the site, and then your NSAIDs, they also work on the transmission to the peripheral nerve. The alpha-2 agonists are your dexmedetomidine and your clonidine, that works on the peripheral and central modulation, and then your opioids work on your mu receptors in your brain. So all the drugs we give work in different ways along this pain transmission pathway. So these are some of the drugs we give for multimodal. So one of the NSAIDs we give is Toradol. So there are some contraindications to Toradol, so sometimes we cannot give it. Ketamine is one we give, which works on the NMDA receptors in your brain, and so that's central modulation. We'll talk a little bit about that in a second. Lidocaine infusions, they work on the sodium channels, but they're also literature that states it prevents hyperalgesia and anti-inflammatory effects, and that it has some role in the NMDA receptor. Magnesium is an NMDA antagonist. So that also relaxes muscles, so it can help as a muscle relaxer to prevent pain. We give IV Tylenol. There was a study done at Zale by Dr. McDonough that looked at the effectiveness for anti-surgeries, PO Tylenol versus IV Tylenol, and that PO Tylenol was as effective as IV Tylenol and a significant reduction in cost. Clonidine and dexmedetomidine Precedex are alpha-2 antagonists. We give gabapentin and Lyrica. These modulate the release of neurotransmitters, which participate in nociception, as we saw in the pain transmission pathway, and then regional anesthesia. So this next one is what happens for pain up in the brain. So you'll see the NMDA receptor is the one on the top left. That's where ketamine works. So when that NMDA receptor is stimulated, sodium and calcium rush in and create this enzymatic pathway that leads to, on the bottom, pain perception and sensitization. So if ketamine blocks this pathway from happening, and especially if you give it preemptively in the beginning, then you don't get that pain perception. So ketamine is an important drug in the role of perception of pain and that sensitization postoperatively, preventing hyperalgesia. And then, again, lidocaine and several other drugs, magnesium, work on this as well. So lots of stuff going on when those things get stimulated. So this is where we tried to do the ERAS symposium, because it's such a multidisciplinary ERAS is just involves all sorts of areas. You know, the important part I think for us as nurses is right now collaboration and education, and then preoperative and postoperatively getting everybody involved as well as in the OR to make sure that it's effective. Because if only one part's following the ERAS protocol, then it doesn't really matter. It has to be followed from start to finish for it to be effective. So. Benefits of.
Oh, sorry.
I can wait.
Okay.
A couple more. Almost done. We have benefits of ERAS, so reduce cost, reduce patient length of stay. There's a lot of studies that use that as a marker if ERAS is successful. There's a lot of newer studies that say that length of stay is important, but not the most important. Reduce complication rate is very important. Decrease opioid consumption, decrease readmission rate, and that's monitored, and then increase patient satisfaction. So, as you said, it's a team that has to work together, and the patient is an important part of that team. Establishing expectations, making sure you're engaging the staff, making sure you have leadership support, which they say is one of the top things, and implementing ERAS. Part of the thing at UT Southwestern that we're kind of backing up a little bit is, you know, we've implemented 8 pathways here, but there still needs to be a lot of education and engagement from the staff. So that's why we're here today. They say
How
that.
do we find out what, like, the pathway? Is there like?
So I'll get you guys a copy
Okay,
for second and third floor PACU, and we'll see if you guys have a folder or binder where you can keep them with us.
Good.
Yeah, we have all copies of them.
Okay.
So for every dollar invested in ERAS returns $4 to the hospital, and length of stay is typically, once the ERAS pathway is successfully implemented, reduced by 30 to 50%, as well as complication rates reduced by 30 to 50%. This is an important part for us. Benefits to nursing, increased practice capabilities and autonomy, meaning that if I have a protocol to follow, but there are deviations from it, I don't necessarily have to call the doctor. This is what I know I have to do. And even though some people feel like it's micromanaging, it's really not, because every patient's different in how they're going to respond in ERAS. A feeling of less work is anecdotal because you kind of know what the expectations are.
Okay.
It meets the goals for magnet status. It meets standards outlined by the ANCC Pathway to Excellence, and it also provides clinical ladder opportunities. Some hospitals actually have a nurse that is an ERAS coordinator, and that is her sole job. I don't know that we'll ever get there or necessarily need it, but I definitely think there needs to be, and hopefully in the future, like a leader in pre-op, a leader in PACU, leader in care coordination, and hopefully that will be the future. Some barriers to implementation: lack of awareness of what it is, reluctance to embrace change, and then again, successful adoption relies on healthcare leadership, staff education, feedback. So some of the other things that are barriers are multidisciplinary consensus. Some people say, well, this is a great thing because for anesthesia and surgery, it's really well researched, but then some people on the floor are like, I'm not going to do that. I don't believe in it. So getting everybody to buy in. There's a common goal. There's a lot of upfront costs to ERAS. So they say that upfront, you know, it looks like you're taking a loss, but eventually you see the difference. And a lot of people are resistant to change, which is one of the biggest things. So as you see, strong multidisciplinary team and communication, hospital leadership, and effective supporters are the top 3 in nursing. Question? I know Margaret had a question. I can follow up with her.
Yeah. What are the